Welcome everybody to our Pacific Spine and Pain Society evidence update on spinal cord and peripheral nerve microstimulation. I am honored to be able to talk about this novel technology and its uniqueness in that it can cover both spinal cord stimulation or dorsal column stimulation as well as peripheral nerve stimulation. As you can see for tonight, we have a wonderful panel, and I just want to emphasize how important this discussion is tonight, and that PSPS really stands for building the evidence and using evidence-based therapies. So it's been great to watch the journey with Nalu, who I've been working with now for 6 years, which is amazing to think about. I remember the cadaver labs in San Francisco General Hospital and to see all the studies that have come out. Our agenda is as follows. I'll just give a brief introduction into the Nalu microstimulator system for those of you who are not familiar with it. And for those of you who are, maybe there's some things you'll pick up. Then Dr. Hathaway, I'll let everyone introduce themselves if you want to introduce yourselves.
Hi, everybody. As Dr. Naidu said, it's a pleasure to be here and an honor to be speaking tonight on this topic. My name is John Hathaway. I'm an interventional pain physician, anesthesia-based in Spokane, Washington. I've been utilizing Nalu extensively over the last 10 years, initially, 2 years, sorry. Initially for PNS, but more recently, I've been utilizing it for spinal cord stimulation as well.
Hi, everybody. My name is Dr. Armin Haratunian. It's nice to meet you. I'm a pain management physician and anesthesiologist based out in Thousand Oaks, California. I've been utilizing Nalu specifically for about 4 years now, and excited to share with you guys my experiences.
And then Dr. Kemlani, if you can just introduce yourselves by audio.
Yeah, absolutely. Hey guys, my name is Vishal Kemlani. I'm an interventional pain physician in Portland, Oregon. Thrilled to be here and, excited to share some insights about the COMFORT study. In my practice, Nalu has really inserted itself into our algorithm, and I've been really impressed with its versatility.
Awesome. And so as you can see, we'll start out with the evidence with the NPower data that Dr. Hathaway is going to present on spinal cord stimulation. Then we'll move on to Dr. Kemlani on the peripheral nerve stimulation data with the COMFORT. Dr. Haratunian has quite a bit of experience on the use of the Nalu microstimulator system, and he'll go through the techniques for different indications. And then we'll have an open panel discussion regarding our own real world experiences, and then I'll finish. So my name is Ramo Naidu. I'm an anesthesiologist, pain physician. I'm the president of the Pacific Spine and Pain Society. I'm based out of Marin County, which is just north of San Francisco. I too, as I mentioned, have been involved with Nalu for 6 years now. I think it's a wonderful technology. I love to see the evidence grow. And the future is very bright for where we're going with both SCS and peripheral nerve stimulation. Next slide. I'm going to talk a little bit about the micro-IPG itself, and this really is a new class in the field of neurostimulation. As we all know, we're very accustomed to having leads and IPGs that are relatively large in the grand scheme of things, even though there's been miniaturization by the other major companies. Generally speaking, the size has been, for some patients, a little bit too much to handle. And I think there are some patients that we've all had who've seen the IPGs in our clinic and then said, no way, that thing's not going inside my body. So to have a miniature microstimulator like this, as you're seeing in this picture, is really appealing for some patients. And we'll talk about which kind of patients we choose this particular technology for. Next slide. So this is really what Nalu is able to do. So the IPG, or the can as we talk about it, is really consisting of different components. And the largest part of the volume of our cans with all the other major companies in spinal cord stimulation is really the capacitance. That's actually the battery part. And really what's really happened over time is Moore's law, our ability to process has improved significantly over time. And so we're able to put a small chip into that 1.5 milliliter micro IPG, take the capacitance out, use that externally, and then send energy to the microstimulator, which then transmits to the lead. So this is a really novel concept in our world. And I think there are, again, a number of patients who benefit from having this miniature micro IPG. It's been FDA cleared for both SCS and PNS, as we've already talked about. The battery's not inside. And there are some patients who don't like the idea of a battery inside their body, thinking, what if that thing leaks? What could happen? So I have had some patients who've actually been more interested in the system simply because of that. It has an 18-year service life. It's one of the longest service times in the industry. And then these are the components down below. So you have a lot of options. As you can see here, you have a quattrode that's untimed. You have a quattrode that's timed. This is really useful for peripheral nerve stimulation, where you're worried more about migration. You also have your traditional octrode, which can be used from either PNS or SCS. And then the micro IPG, based on what you're doing, whether it's a 1 lead or 2 lead configuration, has all of these different tails basically associated with the micro IPG. The external disc is on the right-hand side, as you can see here, and this is where the capacitance is. It actually transmits the energy to the micro IPG, and then you have an app that you can control the stimulator with. It's also able to monitor activity, which can be really beneficial for patients as we're measuring more and more of our functional outcomes. And so we're hoping to see more expansion of these kind of outcomes, as well as potentially even miniaturization of the capacitance over time. So since the beginning, the company's been committed to developing evidence. You're going to hear from the experts tonight. The proof of concept clinical spinal cord stimulation study was in 2016. I got involved with the company in 2017. As I said, I remember helping out the engineers with different types of leads and using it for peripheral nerve stimulation and using ultrasound, et cetera. The first in-human spinal cord stimulation study was in Australia near 2018. And then the Empower US study started in 2020, and Dr. Hathaway will go through that. And then the Comfort peripheral nerve stimulation randomized clinical trial has completed enrollment, and you're going to hear about that from Dr. Kimlani. Next slide. So here's the compendium of the evidence. As you can see here, there are 60 plus peer-reviewed publications. They continue to build. We just submitted it. We're just submitting another one right now. So as you can see, the company is dedicated to building the evidence. They're using physicians that are on this panel, as well as all of you in the audience who are doing these procedures, who can build the evidence and help our patients understand what is right for them. All right, Dr. Hathaway, to you.
Thanks for that introduction, Dr. Naidu. So as I said, I'm honored to be here tonight. I just wanted to say a few words about NALU as a company. All of you can see from the timeline that NALU is a relatively new company, and yet their technology is very exciting and very interesting to use. The other thing I really want to applaud is the fact that being a new company, studies are expensive, especially randomized controlled studies, and it's so important in today's world to have studies to support what we do. This is going to help us get approval for these therapies with commercial insurance companies. Right now, we can do this with Medicare, we can do it with the VA, and we can do it with select commercial insurance companies, but not all. So I really want to applaud NALU for developing data. My part tonight is going to be talking a little bit about some of the early data that's out there for spinal cord stimulation in NALU, and then Dr. Kimlani will talk about the data with peripheral nerve stimulation. So at the root of NALU spinal cord stimulation is the pulsed stimulation pattern, PSP, not PSPS, very similar. This is a multidimensional waveform for multi-mechanistic pain relief, and it's hypothesized that this multidimensional waveform could work on multiple mechanisms of action. And there is some early animal data to support that. When you look at this waveform at the base of this in the darker blue, you can see what we call the dose. And the dose can be on and the dose can be off. And in a sense, this is the large pulse. And each dose is made up of 6 trains. So in the orange, you can see the trains. And again, the train can be on and the train can be off. And then each train is made up of 7 individual pulses. And of course, the frequency of the pulses, the trains, and the dosages, as well as the amplitudes and pulse width can be varied. And by utilizing a multidimensional waveform like this, it's likely that we can affect multiple mechanisms of action. So this is a early study with NALU spinal cord stimulation, and what I'd like to call this is a pilot study. NALU wanted to see if there was a signal for PSP, and they also wanted to see if you could anatomically place leads as opposed to placing leads paresthesia-based. So this was done in 8 centers in Australia and the United Kingdom, and there was a 14-day endpoint. 31 subjects who were indicated for spinal cord stimulation who had chronic pain in the back and legs were entered. The subjects were allocated to both anatomical lead placement or physiological / paresthesia lead placement. And all subjects received 3 days of tonic or conventional stimulation and 3 days of PSP during the trial. And then they exited to receive a commercially available spinal cord stimulation device. And again, I want to stress this was a pilot study, so it was just a look for a signal. But when you look at the data, there was pretty strong data to support the anatomically placed PSP. If we look at pain relief for leg, 63%, for back, 60%, compared to 43% and 46% for tonic or conventional stimulation. If we look at the responder rate, and responder rate is defined as those patients who had 50% or more pain relief, for PSP, which was anatomically placed, we see 78% in the legs and 61% in the back versus 50% and 48% respectively. So since this signal was seen in this original pilot study, this allowed NALU to do a open label prospective study. And this was done both in Australia and in the United States. The top graph here is 3-month results from the United States. And you can see in legs, 76% pain relief, and in the low back, 74% pain relief, and overall an 86% responder rate. Only 3-month data. This is being extended, obviously, and there will be a longer duration of data available soon. If we look at the Australia data, we see very similar results, 86% pain relief in the legs, 70% in the back, with a 73% responder rate. And one interesting thing that some people don't know about the Australian study is that this did occur during COVID, and some of these patients were not programmed for over a year, as NALU could not get back into Australia due to the closure, yet the percentage of relief and the responder rate continues to be quite high. The other important thing out of this study is they also looked at depression and disability, and PSP showed a 45% improvement in depression and disability. And lastly, you already saw what the implanted IPG looked like and how small it is. So there were no reports of pocket pain in these studies. So that's another strong attribute to the NALU system, because as we all know, there's a significant amount of pocket pain with implantable pulse generators, which can be quite a bit larger. So looking at the 3-month data in the United States, 97% of subjects improved in one or more outcomes, and these are both pain and functional outcomes. So there were 0 reports of pocket pain, as mentioned. There was a 94% improvement in activities of daily living. Sleep improved 67%. There was less than 1 reprogramming per patient over that 3-month period. There was an 86% improvement in pain, and there was a 77% and an 84% in improvement in quality of life and mood. So this was important to look at because it not only affected pain, but it also affected all of these other functional outcomes. Patients were getting better sleep, patients were doing more. So pain relief and function at 3 months. So I'm excited to see how this pans out in the next several months. So now I'm going to turn things over to Dr. Kemlani, who's going to talk about data in the peripheral nerve stimulation world.
John, thank you for that. I got to say, every time you present, some of these complex mechanisms behind waveform and technology, I always take home pearls. So thank you for doing that in such a great way that's easy to digest. Now, before we jump into the comfort study, I think it's important to reflect on how we got here and really reflect on the why behind the effort to collect this evidence. If you have your ear to the ground, you can really appreciate the need for high quality evidence to help guide clinical decision making, especially when it comes to incorporating newer technologies and/or techniques into your practice. It's also important to ensure that these therapy options are sustainable in our ever-changing healthcare system, and whether payers will continue to support this therapy, because without that, it's tough to make progress, right? I think we have to also acknowledge that we don't have troves of literature regarding neuromodulation when it comes to peripheral nerve stimulation to offer insight. And specifically, there is, while there's literature out there, there really is some limited level 1 evidence in peripheral nerve stimulation, and this has led to some reimbursement concerns and questions about the efficacy of the therapy. So let's start by taking a look at NALU's efforts to offer us some very relevant data. Now, admittedly, this data set is not from an RCT, but it is a very large-scale survey. It looks at almost 200 patients at over 38 different nerve targets or combinations of therapy. Now, obviously, there's limitations to this type of data, right? It's important to recognize that it's not comparative. We're not comparing peripheral nerve stimulation to, blank, but it's not a small n, right? And the number of targets really reflect how versatile the therapy can be. And honestly, the results speak for themselves. This data is encouraging because it, demonstrates long-term results that are typically seen in things like, modern spinal cord stimulator devices. And not only are we seeing a significant percentage of responders, but also a subset of high responders, as well as levels of pain relief that are not reflected in existing peripheral nerve stimulation literature. With almost 200 patients being surveyed, we see a responder rate of 87%. So specifically, that implies that 87% of patients endorsed at least 50% pain relief or greater, and more than a third of patients were high responders, meaning that they appreciated greater than 80% pain relief from the therapy, which, I would say let that just kind of sink in for a little bit. Those are pretty impressive statistics. Additionally, we're seeing an average of 70% pain relief. So here we have high quality data. And while it's not controlled, it certainly is promising. What I think is going to be really interesting is to see how the real world evidence compares to RCTs that follow patients long term. And this is really where, in my opinion, the literature can help guide clinical decision making and influence our individual algorithms. And that's really kind of where the rubber meets the road. And that's what brings us to the COMFORT study. So the COMFORT study is one of the largest RCTs in peripheral nerve stimulation. It's a post-market, multi-centered, randomized controlled trial study that takes into consideration input from payers with intentions to demonstrate value and outcomes in an actionable manner. I really enjoy the design of the study itself because it's so easy that even I can understand it. There are two arms, right, with the control being conventional medical management and the active arm being conventional medical management, or CMM, plus NALU peripheral nerve stimulation. Patients are, once enrolled, are randomized in a 2-to-1 nature, from 2 being in the active arm, 1 being in the control. And once they're randomized, they go down one of these 2 pathways, either to conventional medical management alone with routine follow-ups. And at the 3-month mark here, you'll see that they have the opportunity to cross over. And meanwhile, while patients who are randomized to the therapy arm will undergo a trial, and if successful, will move on to a permanent implant. These patients are then followed up for 12 months thereafter. Now, what the study is actually looking at are patients diagnosed with either one of the following, right? Post-surgical or post-traumatic peripheral neuralgias, mononeuropathies, other neuralgias, as well as osteoarthritic pain, right? So we have a nice wide subset of patients. And what I really enjoy about this is that these are patients that are that were easily kind of found in our practices, in our kind of day-to-day routines. These are not kind of patients that were particularly cherry-picked. We also have 4 very useful anatomic locations, so specifically the shoulder, lower back, knee, and foot. So, with regards to primary endpoints, of course, we have our sine qua non, right? The NRS is the primary endpoint. But I think it's worth really spending some time and to focus on the secondary endpoints. Specifically, we have the Oswestry Disability Index, quality of life, patient's global impression of change, brief pain inventory, Beck depression inventory, pain catastrophizing scale, patient satisfaction, as well as patient comfort. And in my opinion, the holistic nature of these outcomes, both primary and secondary, as well as the design of the study itself, really speak to the scientific rigor of this RCT. So without further ado, let's so this is the latest published cut of the data, and this was presented at ASIP in March. And yes, it's a small sample size, and undoubtedly it's early data, but the outcomes are promising and significantly better than what we've seen in the past, right? So looking at responder rates of 81% of patients in the active arm compared to 0% in the control. And if we factor in pain relief and or patient's global impression of change, we're looking at 100% responders. So patients in the active arm also endorsed functional improvements of 57% compared to 3% in the control. And I think it's worth noting there were no serious adverse events and no incidents of pocket pain. Right, so I think it's important to highlight that pain relief in this situation is the primary endpoint here, not the combination of the 2 parameters, pain relief and PGIC. But what I think is even more impressive is that the responders are characterized by 50% pain relief or greater, which is very different than the 30% pain relief or greater metric used in prior peripheral nerve studies. So, here we have it. I think Nalu is really the first company in peripheral nerve stimulation to really bring SCS level, results to the realm of peripheral nerve stimulation. We can see that there's some pretty encouraging outcomes with regards to real world evidence and very encouraging data coming out of one of the largest RCTs in peripheral nerve stimulation. And I think this really exemplifies the efforts and the value that the team in Nalu are trying to bring. And I'm really encouraged that the industry is really taking this kind of initiative, because I think it's important for all of us, for our patients, for the payers, and for our field. And with that, I'm going to hand this off to my good friend Armin, who's going to take it away.
Hi, everybody. Thank you, Dr. Kamlani, for that wonderful background and introduction. Dr. Kamlani and I actually go back to a few years ago when we had our first discussion about peripheral nerve stimulator. It was more of a peer-to-peer, and we just kind of talked about it and talked about the therapy. And it just comes to show that the therapy is easily integrated into practice, because clearly now Dr. Kamlani is doing peripheral nerve stimulation. So I'm very happy to see him here. That pretty much brings me to the point where I've been doing peripheral nerve stimulation for about 4 years now. I came out of practice and I joined 2 older colleagues of mine who were not doing peripheral stimulation at the time. And now they are happy to be integrating this technology amongst all their patients. And we probably do between 10 to 15 a month. And it just comes to show that these patients do exist in your practice from a spinal cord stimulation and a peripheral nerve stimulation perspective. And all you got to do is just follow the algorithm, and then they'll start appearing out of nowhere. So once again, I'm a peripheral, and I'd like to brand myself as a peripheral pain physician. I see a lot of peripheral pain in our practice. A lot of the peripheral pain comes my way, and so I've liked to create this kind of relationship with the surgeons in my community. And initially I started with podiatrists in my community to help manage some podiatric foot pain, some of the recalcitrant Achilles tendinopathies, plantar fasciitis, etc. And so that kind of opened my pathway to tibial nerve stimulation. and that sort of opened my doors to other kinds of peripheral nerve stimulation. So I'd like to talk about my experience and some techniques that'll help you guide your way through the operating room, both ultrasound and fluoroscopic guided. So here we have a depiction and an image of spinal cord stimulation therapy. We're all familiar with it, but alas, we finally have a method to perform spinal cord stimulation with a single incision method. So clearly this small microchip IPG, which I've also brought with me, I'd like to demonstrate that the single incision, which is used for the midline for the anchoring, you can use that same pocket as shown here. Using that tool, you can create a subdermal pocket and insert your implantable pulse generator just lateral to where the patient would like to place their external power device. And so this saves us not only time in the OR, but saves the patient from incision pain. It reduces the risk of pocket seroma and significantly reduces the risk of infection. And we all know that once every 5 to 7 years, some of these traditional spinal cord stimulator batteries end up needing a replacement. So for a lot of your older patients with comorbidities, this is a phenomenal alternative in which they don't have to come back once every 5, 7 years, undergo the risk of sedation, etc., where you can get by with this device that's proven now to be 18 to 20 years effective. It's hermetically sealed device. It's been tested under accelerated testing, and all of these studies have demonstrated an 18-year life capacity. So this is the size of it. It's about the size of my index finger. So as I was saying, there are certain candidates that are great candidates for this therapy. Of course, your younger patients who want a cosmetically nicer appearing device. They don't want a bulky battery hanging out of the flank. You've got your older pain patients, which we just discussed, who have multiple comorbidities. You don't necessarily want to bring them back every 5, 7 years. You've got your low BMI patients who don't have much subdermal tissue or fat in which to create that space for the generator. And so the external device becomes a valuable option. You've got your battery averse patients, which now we know 2023, everybody's Googling, everybody's microchipped and freaking out about information warfare. So these battery averse patients, I think, is an excellent option for you, especially in Southern California. You've got your episodic pain patients, and this is really interesting. Some patients will have pain a few hours a day, only nocturnal at night. So it's nice to be able to afford the therapy. They can just slap on the therapy disc, turn on the device, and they don't have to wear it the rest of the day. You know, they can only pulse dose it a couple hours in the morning, a couple hours at night. I've got a suprascapular patient who only utilizes it for about an hour to 2 in the morning, and she's good for the rest of the day. So that pulse dosing therapy does really work, and they get pretty good continued pain relief. So PNS patients, like I said, they do exist within your practice. I think peripheral nerve stimulation has been quite anecdotal thus far, but thanks to the foresight of NALU and the Comfort 1 and Comfort 2 trial, I think that we're finally ending up with good randomized control trial data with 80+% efficacy. So this is very, it's not only encouraging, but it's also very important for future generations to employ and continue to develop on this peripheral nerve stimulation platform that we already have. So peripheral nerve stimulation now with NALU has improved dramatically. As we saw earlier in the slides, we've got tined lead technology, which I'll talk about in a minute, but I think that's the beauty of NALU. The tined leads really do cut down your surgical time, and they do reduce your incision. Not only do we have the PSP technology that Dr. Hathaway touched base on, we've also got current steering now. So for example, if you're stimulating a big sciatic nerve and you're really trying to capture, for example, a tibial component, you can change the leads, you can change the current and try to capture only a certain part of that sciatic nerve. So the technologies have dramatically advanced. It is cost effective. You know, I always talk about wanting to do, for example, a genicular nerve ablation on a patient versus considering doing stimulation. Now, as we all know, peripheral nerve ablation is about 65% effective. At best, 50% of the patients will have continued pain relief at the 6-month mark. So if somebody's 50 years old, am I going to ablate their knee another 60 times until they reach the age of 80? Not exactly. So having that frank discussion about how effective something is and how long it lasts for, 6 months versus 18 years potentially, I think is a good way to break the barrier. It's very low risk. Again, the pocket size is very small. You can get by with a single incision technique. Some patients you can continue anticoagulation on. If you look at the ASRA guidelines, of course, it's a shared risk assessment when deciding if you want to continue the anticoagulants. But in patients who cannot get that cardiology clearance, performing, for example, a genicular nerve or tibial nerve stimulation under anticoagulation, if they are high risk, is plausible. Favorable reimbursements. Like I said, with those timed leads, you're cutting down your operative time. Now we've got validated CPT codes for the facility and professionally. And so, cutting down your operative time with those favorable reimbursements have made this quite user-friendly. And of course, an optimal salvage option. A lot of us are now seeing these temporary percutaneous stimulation devices, which are effective, but oftentimes after a 60 or 90-day trial, these patients will come back wanting continued benefit and continued relief. So I think it's a nice way to salvage some of these therapies. We have a lot of patients in our practice who have spinal cord stimulation therapy for failed back with continued lower extremity radiculopathy. There's one that comes to mind. And so it's a nice way to manage that radiculopathy, for example, in somebody with a continued L5 nerve compression with a fusion and an SES device who has continued right leg pain. You can obviously consider doing something like a sciatic nerve stimulation to capture that pain. So these patients do really exist in your practice. And of course, a low barrier of entry. I think, of course, we're Gen Z, millennials, it's the joystick generation. Everybody is learning how to use an ultrasound and three-dimensional continued imaging, but some of these things can be done still under fluoroscopic guidance, and we'll touch base on that. Most notably, cluneal nerve stimulation, which is probably the most common, suprascapular nerve and genicular nerve stimulation, which can all be accessed fluoroscopically. So nerve blocks, a lot of patients, providers will ask, would you do a nerve block to rule in the diagnosis? Well, nerve blocks are great. Nerve blocks are very specific in which they will rule in the patient's pathology, but they're not very sensitive. So it doesn't necessarily rule it out if the result is not positive. That being said, do I perform nerve blocks personally? I do. I perform them on the geniculars. I perform them on scapulars and suprascapulars, and I perform them on lower extremity for a variety of reasons. I think that number one, it gives the patient something to look forward to. So if you can give them a few hours to a few days of relief, it makes them more willing to proceed with the stimulation therapy. Number two, if you're dealing with private insurances, I think it gives you more ground to stand on if they do get a positive diagnostic response. And number three, it makes you accustomed to the patient's anatomy. There's always going to be some level of anatomic variability. So if you do a nerve block before bringing them into the operating room, for example, an ultrasound guided tibial nerve stimulation, you're already accustomed to the anatomy, you know how to approach it, you know where the vasculature is, and it's going to be a lot easier and quicker for you to get in there. So, but that being said, cluneal nerve blocks, for example, they're not very sensitive, and that's because there's a lot of variability of those cluneal nerves hanging over the iliac crest. So your 3 milliliters of Marcaine aren't necessarily going to cover all those peripheral branches of the cluneal nerves. But I'll dive into that as we go on to that. And of course, trials are critical. I like NALU because you can have a nice apples to apples comparison of trial to implant. And so if a patient does well with a 4-contact or 8-contact trial, you can go on to proceed with the same exact therapy with the same exact settings. So you're going to get a very good comparison of the trial, which is going to increase your outcomes. And so the first patient I'd like to touch base on is the suprascapular nerve. This is probably the, I'd say the third most common implant trial and stimulation that I do in practice. These are going to be your patients with chronic shoulder pain that are either post-arthroscopic, post-replacement, they're too sick or elderly to undergo surgery, and the patients that aren't getting enough relief with the traditional suprascapular block or suprascapular nerve ablation. I want to bring to your attention though, suprascapular nerve ablation, if you do proceed with thermal ablation, you got to watch out for neuritis. I have seen it. And so there's always that thing going on in my head about, do I want to take the risk of neuritis versus implantation with suprascapular nerve stimulation? And of course, I always think about the conversation of, are you going to do an ablation and then try stimulation if it fails? Well, if you do that, you're going to want to probably wait 3 to 6 months before you try stimulating an already ablated nerve. Rather than trying a stimulation pathway first, you can always ablate after, if that makes sense. So that being said, I'd say 50% of my patients are pre-surgical or non-surgical candidates because of the comorbidities, and the other 50% are post-surgical, rotator cuff, total reverse shoulders, etc. Suprascapular nerve, I want to remind you, is responsible for innervating the supraspinatus and infraspinatus, which we know is responsible for shoulder abduction and external rotation. And it's a peripheral branch of your C5-6 nerve fiber. It's responsible for carrying about 70% of the sensory input of the shoulder. So some people always ask, are you going to bother doing the axillary nerve as well? Well, I think if you're giving somebody with chronic pain 70% relief of the shoulder, and you do a suprascapular nerve block and they get good relief, I usually don't bother performing the axillary. I think they do just fine with suprascapular nerve stimulation. So again, the workup's going to be a diagnostic nerve block, which you don't have to do, but you can if you'd like to rule it in. You can do the obviously the wear experience, where a patient is given the external battery and they get to wear it for about a week and see where they like the device placed. I think this is very important. Nalu has very good foresight in encouraging this, because obviously if the patient's not going to feel comfortable in the area where they place this external generator, they're not going to be utilizing the device, and that's going to translate into device failure. And so traditionally for these, I will either place it over the clavicle across the chest, almost like a pacemaker, or with a single incision technique over across the back. As long as the patient doesn't have bilateral shoulder impingement, they can easily access the posterior shoulder to replace and take out the battery. The approach for this is either going to be ultrasound guided or fluoroscopic guided. I think both are very feasible. I started doing them ultrasound guided. Now I do them fluoroscopic guided because I believe there's more reproducibility. You can always take a picture and see if there's lead migration. I think that's very important if you lose efficacy. So that's one thing to consider when doing this, is obviously taking even if you do it ultrasound guided, taking one final picture with fluoroscopy to make sure that your leads are in the right place. You can always monitor it and see if there's lead migration. So the approach for this is going to be medial to lateral. The patient's going to be lying prone, and you're going to be tilting the eye a bit caudal. And so that's going to allow that acromion to get out of the way, so you get a nice view of that supraspinatus notch. Once you get a nice view of that notch, you're going to dive down with the needle, medial to lateral. The TUI is going to touch os in the posterior shoulder of the posterior scapula, and then you're going to ride that TUI across the posterior scapular notch all the way to about 3/4 of the lateral process. And I usually place 2 leads for this. I don't like to risk lead migration, and so I always like to not only trial, I also implant with 2 leads. And you'd be surprised, sometimes the lead that's actually farther from the notch will give the patient better stimulation. It's interesting, but I think every day we learn a little bit more. On the right, you see the ultrasound guided approach. When you do use the ultrasound guided approach, I would advise not going into the suprascapular notch. There is the big suprascapular artery, which if you hit with your TUI needle, might result in some bleeding. And so I like to kind of glide over that suprascapular notch and place my trial leads over there. Also, a medial to lateral approach with the curvilinear probe helps you see the suprascapular notch quite well. Alternatively, you can do a combined technique, because I think realistically the most feared aspect of this procedure, and I'm going to be honest, is going to be lung puncture, right? Everybody's worried, am I too deep? Am I going to be worried about a pneumothorax? One way to mitigate that is you can use a spinal needle almost as a finder needle, right? You can use your spinal needle, go into the depth of the suprascapular notch, and that'll give you a good depth and good understanding of how deep that suprascapular notch is, so that when you do use your TUI, you will have a better and more comfortable understanding. But I think if you use the landmark technique, which is going in the border of where that clavicle meets the first rib, that's a very safe landmark. You're going to go down, you're going to hit os, and you're going to go from medial to lateral, all the way, like I said, to about 3/4 of the lateral process. Okay, and so this is the superior cluneal nerve stimulation I like to talk to you guys about, probably one of the most commonly employed stimulation patterns now that we're using in our practice. This is commonly used for low back pain. It's focal or unilateral. Traditionally, the ideal patient is going to be the patient with reproducible tenderness to palpation over that iliac crest, about 5 to 7 centimeters lateral from the midline. You may or may not see a positive Tinel sign over that iliac crest. And if a patient's really obese, you're going to have a hard time reproducing that Tinel sign, but a deep palpation will certainly reproduce that pain. Sometimes patients will describe it as a burning sensation emanating from the iliac crest, spreading up and out almost like a sunburst pattern. These are the patients that are not going to get improvement with the facet injections and the ablation therapy. Epidurals aren't going to alleviate that axial low back pain. Patients with fusion, sometimes a lumbar fusion can cause scar tissue. And as we know, these superior cluneal nerves are exiting from like your T12 to your L2. There is some variability at where they exit, but when you think about it, from T12 to L2, there could be a lot of scar tissue. And as these nerves exit, they exit through an osteofibrous tunnel. As they exit through the tunnel, they travel over that superior iliac crest and they dive over the crest. So as you can see, there's a lot of, there could be a lot of variability of where those nerves lie. Hence, diagnostic cluneal nerve injections are super variable. You know, they may or may not work. When patients fail the cluneal nerve block, doesn't necessarily mean I'm not going to proceed to a cluneal nerve trial. I'm going to proceed to the trial because with those 4 or 8 contacts, you're going to be stimulating along the entire span of that iliac crest, and you're likely going to get a much better stimulation pattern. And so that being said, the stimulation is done from a medial to lateral approach. I like to dock on the posterior superior iliac spine. And once I do, I drop the angle of my needle and sort of right along that iliac crest until I'm about 50% of the width of that iliac crest. Again, I like to use 2 contact points if it is unilateral, but typically these are done in a bilateral fashion. And it helps mitigate and manage a lot of that axial low back pain. And if you could imagine, that proximal lead is going to be pretty close to the sacroiliac joint as well. So in patients with low back pain and some element of sacroiliitis, you get pretty good relief of both of those components. And so this has been a pretty big slam dunk for us in our practice. We've been able to capture a lot of that failed back patients with spinal cord stimulation therapy, where the therapy kind of dwindles off and doesn't really take much effect. We've translated them, we've done explants and done the cluneal implants with very good success thus far. And so this will probably be one of the most commonly employed techniques in your practice if you're not already doing it. And I know the picture demonstrates those those leads perfectly over the iliac crest. And realistically, it doesn't have to be right over the crest. You can be a few centimeters below it, because as you can see on the left, those nerves are going to be gliding all the way down, and you'll get good stimulation pathway there as well. All right, and so this is the genicular nerve patient. Most of you already know much about genicular nerve stimulation. I don't have to tell you much, but I will anyway. These are the patients who are going to have chronic knee pain. A lot of them are going to be post-operative. Some, again, are going to be preoperative. Too many comorbidities to proceed with surgery. As we all know, a lot of these chronic pain arthritic pathways are nociceptive, right? But over time, there's a lot of windup of these nerves. These nociceptive pathways end up translating pain from a neuropathic perspective from windup. That's why gabapentinoids work great for these chronic osteoporotic and osteoarthritic patients. And so I think there's a great utility of trying these nerve blocks. A lot of providers ask me, would you just do it for osteoarthritis? I would. It works well. We have done it with good success. But I think your slam dunk patient is going to be the one with a knee replacement with scar tissue that's going to be compressing some of those genicular nerves. Genicular nerve ablation is about 65% effective. Stimulation is closer to upwards of 80 to 83% effective. And that's going to be because there's a lot of variability of those little genicular nerves. I do these typically the blocks under ultrasound. And with ultrasound, you can see there's a lot of variability of the genicular nerves along that femoral condyle, along the epiphysis diaphysis junction. And so if you think about it, you might miss one of those spots if you're just going to be doing an ablation therapy, hence why the 65% efficacy. However, with stimulation using 4 to 6 contacts, you're going to get a lot of that bandwidth along the femur down to the diaphysis metaphysis junction. So similar to your endpoints of genicular nerve ablation therapy, if you've done this fluoroscopically, your endpoints are going to be similar for the nerve stimulation. And so you're going to approach this in an AP fashion. You're going to come down and hip bone, and then as you hip bone, you're going to switch to lateral, and you're going to make sure you maintain that 50% width of the depth of the width of the femur as you come down and lateral. And so once you get good at this, this will be a very efficient and effective procedure. You can get by doing this pretty quickly in the operating room. And so now I've been using tine leads. I think 4 contact tine leads are plenty for this as well, and allows you to get by again with a single incision technique. And it looks pretty slick when the patient walks out of the OR with a single incision getting by with a genicular nerve stimulator. And so that's pretty much the gist of knee stimulation. I think these patients do really, really well. Once they hit the door and once you get a couple under your belt, I think you'll get very comfortable at doing these quite quickly. And last but not least, tibial nerve stimulation for chronic foot pain. These are going to be patients with plantar fasciitis, recalcitrant Achilles tendinopathy, Charcot foot that's non-operative, tarsal tunnel syndrome, Baxter's neuritis. I mean, there's just so many pathologies that can present for the foot. Isolated radiculopathies. These are typically on label for mononeuropathies, which work really well. Decompressive surgeries are effective about 50 to 60% of the time, and your peripheral surgeons will tell you this as well. So I think a lot of the algorithm is changing for peripheral surgeons to, will I put a patient through a decompressive surgery with 50% efficacy, or send them over to the pain physician for a stimulation of closer to 80% efficacy? So the tibial nerve, as we know, carries a majority of the pain of the foot, about 70 to 80% of the medial and plantar aspect. And so a diagnostic block for this works really well. About 2 to 3 mLs of Marcaine works for a few hours to a few days, believe it or not. The approach for the stimulation is going to be a posterior and superior to inferior. What does that mean? It means you're going to start proximal up about the area of the mid-calf, and you're going to be diving down distally to the area of the medial malleolus, and that's going to be your endpoint. You want to stay posterior because, as you can see on the screen, you've got that pulsating red tibial artery. And so if you do stay posterior, you're going to be staying very clear of any arteries or any vasculature that's going to be in your way. I find that even if you're 2 to 3 to 5 millimeters away from the nerve, you're still going to get very good stimulation of that nerve. And that's kind of the power that the NALU technology has. And as of late, we've learned that you can increase your pulse width to capture a greater amount of that nerve stimulation coming down. When you do this technique, when you go superior to inferior, you're staying basically parallel to the nerve. And so theoretically, you can stimulate all along the length of that nerve. There's a lot of questions about, do you want to stay parallel or would you want to stay perpendicular to nerve? I think that's still something that we're discussing to date. But in this technique specifically, you will be staying parallel to the nerve and theoretically can stimulate all along its length. These patients do quite well, and I put them through the gambit of the diagnostic nerve block. I trial them with 2 leads. I typically use the 4 contact tine leads because, again, you can get by with a beautiful single incision. And I'm gonna re-emphasize that the beauty of NALU are those tine leads, and they really help reduce your operative time. And I think this is the final slide for me. This is a slide on the NALU Academy. I think this is a great way for patients, rather providers that are interested in continuing building our implanting community, sharing their experiences. I've been faculty for NALU Academy with some of the other presenters on this webinar. And if you want to continue the peer-to-peer dialogue, continue some of the education and neuromodulation, you can click on the link and sign up, and we'll be happy to continue our care with you.
All right, thanks so much, Armin. That was fantastic. I appreciate that. Gave a little feedback. So we're going to open it up to the entire panel. We can see the video for Armin and John, and Dr. Kimlani is also on. So my first question is for Dr. Hathaway. With all of the different spinal cord stimulation options on the market, I believe we're up to 8 now. Why do you choose NALU for your patients?
So great question. But we seem to have an echo for some reason. Anyway, that's a great question. And if we went back to when I first started using NALU, I was really only interested in using NALU for PNS. I was fixated on using what I use for spinal cord stimulation. And in fact, I think if someone marketed me NALU at that time with SCS, I probably would have been a little bit turned off and may not have used NALU for PNS. But I've used it extensively for PNS. And as I've done that, I think my main bias wasn't true. And if you would have asked me what my problem was with NALU with spinal cord stimulation at the beginning, I would have said, why would somebody want to wear a disc for spinal cord stimulation when they can have a implanted pulse generator? And if we think about it, one of the main complaints I get from traditional spinal cord stimulator systems is recharging. And patients have difficulty getting a signal between their recharging belt and their implanted generator. And that's a complaint that I get quite a bit. Well, with NALU, a patient, particularly older patients, can take their disc off of their charger on their nightstand, take the discharged one off and put the newly charged device on, and it's as simple as that. Another thing I think that's really important and some people may not know about is that you can control the entire system with the disc itself. Yes, there is a smartphone app, but a lot of older patients have difficulty with smartphones, and you can turn the device on, you can turn the stimulation up and down just utilizing the disc itself. So that makes it a really simple option for these patients. And Dr. Hartunian also mentioned the size of the IPG decreasing the risk of infection. And more patients that I see have diabetes and are at increased risk of infection with implantable therapies. And with a single incision, or even if there are two small incisions and this small pocket, that risk of infection is a lot less. And as we saw from some of the studies, pocket pain is virtually non-existent. So taking all those things together, I'm finding more and more patients to be great candidates for spinal cord stimulation with a micro IPG.
Thanks, Dr. Hathaway. And the next question is for Dr. Khemlani. If you were to train a young neuromodulator, I'm sure we have many in the audience tonight, including fellows, who are specifically interested in peripheral nerve stimulation, which three indications would you have them master given the volume of patients that are coming through clinic, the techniques as far as how easy or hard it is, and then of course the reimbursement and coverage? So which would be your three indications?
Yeah, that's a great question, Ramo. You know, I'm tempted to say number one and number two would be the coverage of the superior cluneal nerve. I think Dr. Hartunian really kind of hit that home, and I think that not only can we get kind of the holy grail of axial lower back pain, but there's a lot of opportunity to salvage here. So again, as I think everyone here has emulated, these patients are really there in your practice. If someone's doing well, then there's nothing to do with them. But if they've had a trial or even an implant and they continue to have lower back pain, I think this is just such a great option for them. And obviously, even if they haven't had a trial of spinal cord stimulation, this is something that I think about before, reaching for something to modulate at the dorsal column. The second, I've been really successful with treating foot and ankle pain. I work with several podiatrists and see a lot of volume from them. And I take a slightly different technique than Dr. Hartunian. I'll go just a little bit more proximal at the sciatic nerve right before the bifurcation at the popliteal fossa. So, as an anesthesiologist, I'm quite used to blocking that nerve prior to patients going into the OR for through regional anesthesia. And so I think that's a target that I've been really comfortable with. It's very easy to see. You can appreciate the vasculature, and it's a really quick and easy procedure. And then finally, genicular nerve. Again, I'll kind of echo some of the comments of Dr. Hartunian. These are home runs. Patients who have already gone through, the knee surgery, the total knee, and they still have that knee pain. As long as they don't have any mechanical issues with it, which the orthopod will be quick to tell them that their knee looks good, and the fact that they still have knee pain, I think these patients really need our help, and the approach is really it's really quite approachable. So those would be my top targets, and I'd really encourage those on the call today to really think about these and reach out to their local rep to kind of see how they can get it, go about introducing this into their algorithms.
Perfect. Thank you, Dr. Khemlani. And last question for Dr. Hartunian, and you have 30 seconds to answer this. So you did a fantastic job explaining all the different techniques for the different indications. where did you learn all of this? And as you do so, I just want to make a note that the PSPS annual meeting will also do a number of ultrasound demonstrations for different nerve targets. But I'd love to hear from you how you became proficient at all of these techniques.
I think integrating from an early stage in fellowship is really important. And of course, after fellowship, reaching out to some of my reps from NALU. At that time was StimWave, but now I luckily work with the same rep. They have a lot of valuable resources. They have a lot of video recordings, a lot that some of us have even done that are demonstrating the ways to implant. And not only that, I think the NALU Academy has done a great job. I've seen a lot of physicians from all over the United States come to some of these NALU Academy meetings where we host labs, and it's been of great value. We'll have multiple stations, tibial, suprascapular, cluneal, nerve stimulation, and genicular, and that's where you really get your hands-on opportunity and takes you from a comfort level of, kind of being on the fence to really comfortable in stimulation. So I'd say utilize that NALU Academy definitely.
Thank you. That was wonderful. So there were a number of questions that came from the audience. I'm just going to answer them very quickly just for the purposes of time. So there were a few questions about the cluneal nerves. I love it because this is really an undiscovered, uncharted area for anatomy and understanding a pain generator of the buttocks. So I think all of us know that are on this call at least that we have 4 different types of cluneal nerves: superior, middle, inferior, and lateral. The derivations come from the thoracolumbar and sacral nerve roots. You've heard from Dr. Hartounian about the superior cluneal nerve placement, the diagnostic block. For the middle cluneal nerve, it's under the PSIS and then fanning underneath. Make sure you don't get into the sacroiliac joint because you don't want to confound your pain generator. The lateral cluneal nerves go out laterally along the mid-axillary line along the iliac crest. The derivation there is L1, give or take T12 and L2. And then the inferior cluneal nerves are a little more challenging. They run underneath the gluteus maximus. And the interesting diagnostic conundrum there is, are you dealing with ischial bursitis versus hamstring tendinopathy or an inferior cluneal neuralgia? And I just had a patient this week who had an inferior cluneal neuralgia and entrapment underneath the gluteus maximus. So there are different ways of doing this, whether fluoroscopically. What I like to do is I use 5 cc's of 0.25% bupivacaine, and I add 2 cc's of contrast. And when I do my diagnostic blockade, no steroid, I fluoroscopically save my image of what I'm doing. So I'll walk the needle along the iliac crest for the superior cluneal nerve, and I'll save that. And if the patient does well, then I know exactly my target for the octro that Dr. Hartounian showed. And similarly for the middle cluneal nerve, I'll do the same thing underneath the PSIS. So you have to save those images. You have to see what you're doing, because if you just inject, you don't know where the heck your fluid is going for the cluneal nerve system. Really important to monitor that using contrast. There are a number of questions regarding the coding. I'll ask you to talk to your NALU representative. That changes from region to region, depending on your MAC, depending on the payers, as far as what is covered, et cetera. And then there was a question about whether PNS is effective for nociceptive and neuropathic pain, and the answer is yes. As you can see here, Dr. Hartounian mentioned the knee, the shoulder as options, the major joints. Absolutely, we're digging more and more into how much peripheral nerve stimulation can address nociceptive pain in addition to neuropathic pain. So thank you for all the questions. I know there are more. Hopefully we can answer those afterwards or through your NALU rep. Lakin, let's go through the slides, and if everybody can get their cameras, because I'm going to have a ton of QR codes here. So I want to talk a little bit about our PSPS events. Dr. Pope is going to be leading an APP webinar. So you can QR code that for when that is. Next slide. We have our minimally invasive spine lab in Denver, Colorado on June 3rd. Encourage all of you to come. As you know, we did our neuromodulation lab in Portland in early April. This now will focus on minimally invasive procedures performed by interventional pain providers. We are also, next slide, going to have a surgical lab where orthopedic and neurosurgical surgeons and their fellowship are going to be taught different types of spine surgery techniques. But we're also going to talk about the crossover procedures such as spinal cord stimulation, which you've heard about tonight, as well as indirect lumbar decompression. And then there's a call for abstracts. So our PSPS annual, you'll hear in just a bit, is in September in Hawaii. There is a call for abstracts. So if you have any type of data research, fellows, you're definitely encouraged to do this. Please submit your abstracts to the Research and Scientific Planning Committee. And then research grant proposals. So what we have done as a society is provided grant funding. It ranges from several $1,000s depending on the size of the project and how many subjects. And it's an annual stipend in order to promote evidence-based research. And we really want people to tackle some of the issues that, for example, industry-sponsored studies cannot. So we've seen some great proposals come over the last few years, and we're looking forward to more. So please, if you're considering something, we can help sponsor that. Next slide. And then last but not least, this is our annual meeting. I'm super excited about this. This is our fourth annual meeting, and it's going to be at the Four Seasons in Oahu, September 7th through 9th. As you heard, we're going to be learning about ultrasound techniques for peripheral nerve stimulation. We're going to go through the huge myriad procedures that interventional pain providers and spine surgeons perform, and it's going to be in an idyllic setting on the west side of Oahu. I encourage you all to come. It's basically the weekend after Labor Day. It's going to be a lot of fun. So with that, I want to thank you all for staying a couple minutes later. Appreciate Nalu for the opportunity to describe the evidence that's been produced. I want to again thank the panel, Dr. Hathaway, Dr. Kemlani, Dr. Hartoonian. I think this was a wonderful panel, a wonderful discussion on SCS and PNS and microstimulation. I hope you all have a great night. And again, feel free to contact us at our PSPS events and feel free to reach out to us with any questions. Thank you so much.
Thank you.
Thank you.